Welcome, everybody. We'll get started. It's 10:15. Everybody hear me? Yeah, sort of. Better. Welcome to the Blood Cancer Patient Forum. This is our breakout room, and the topic that we have for the next 2 or 3 talks is lymphoma. And as Peter, you might have, our CEO, mentioned earlier on, next Saturday, the 15th, is World Lymphoma Awareness Day. So that's, the theme this year is small things build confidence. So, the little things in life that help, build your confidence, build your mood. So, it doesn't always come from one major thing, as David Down spoke yesterday about the little things that went right in his life and the little things that built his confidence and got it up. So it's kind of a good topic given what we spoke about yesterday. So we'd love you to share those little things that help build your confidence. You might have seen the whiteboard with the sticky notes, and it would be really, really great if you have anything that you thought would be good to share, because we will do something with those later in the year. Without further ado, I'd like to introduce our first speaker, and that is Dr. Henry Chan. Henry graduated from the University of Auckland in 2007, and subsequently began his haematology training in 2011. Following completion of his training, he went to Toronto, completed a clinical fellowship in myeloma and lymphoma at the Princess Margaret Cancer Centre, and now he's currently working as a consultant haematologist in the North Shore Hospital in Auckland. And his interest includes myeloma, lymphoma, clinical research, biostatistics, and teaching. So if you want to put your hands together, we'll introduce Henry. Henry will talk about indolent lymphomas and CLL.
Good morning, everyone. So, yes, I am Henry. First of all, some of the fonts in my slides are quite small. So, if you want to move forward and sit closer to me, that's okay. So, I don't mind. There's a button right there. You can sit there. Okay. So, today I'm going to talk about indolent lymphomas, CLL. And as some of you may know, I'm quite casual. I like to talk about the big picture. I like to talk about all the things that I'm sure your clinicians or your read stuff online about it. So we're going to cover the basics. We're going to talk about, what are the standard treatments, what else is out there, what the future is like. I don't think my talk will go for 15 minutes. Okay. In fact, I think my talk will only go for about 30 minutes. And so we'll leave plenty of time for questions at the end, because it is quite hard to do a talk on this topic. Okay. This topic, indolent lymphoma, covers a wide range of conditions. And some of you may have recently been diagnosed with lymphoma, some may have received treatment, some may have family members who have lymphomas. And so it is really hard to, tailor the talk so that I can address the need for everyone. So in that case, what I've done is I'll just cover everything, and then we can ask questions, and hopefully I can answer most of them. Okay? So once again, indolent lymphomas and CLL. So when I asked my wife, what is the best way for me to give this talk? She said, well, your patients like to talk to you. They like to come to the clinic and spend time talking to you. So just treat this like any other consult. Okay, so instead of having one patient in front of me, I have 30, 40 people in front of me, but still. So pretend that you are now in my consult room. Okay, so we're going to go through all the things that I'll typically say to my patients when they have lymphoma. Okay. So first of all, lymphoma, it is a form of cancer. It is a cancer of the lymphocytes. We all have lymphocytes in our body. They're part of the immune system. Okay. As you have heard earlier today by Professor Morrison, that we have lymphocytes in the bone marrow, they develop, and they're there to fight off infection. For various reasons, sometimes they become abnormal. They start growing uncontrollably. And when that happens, that is lymphoma. Now, these lymphoma cells or lymphocytes, they originate from the bone marrow. As they mature, they go to the lymph nodes to do what they need to do, to look after your body as part of the immune system. They go around the body to keep an eye out for infections. And so most of the time when lymphoma happens, they get big lymph nodes because that's where they live. Lymphoma can also happen elsewhere in the body. In fact, any place in the body. Skin, organs, lungs, even brain. And of course, the bone marrow. And that's why quite often when you come to the clinic and you've been diagnosed with lymphoma, we say, well, we need to do a CT scan. Yes, we found some lymph nodes, we need to do a CT scan to see where else is involved. And unfortunately, we still need to do a bone marrow biopsy these days because, yes, we can look at the bones on the CT scan, but we can't look inside the bone to see if the lymphoma is there. So we still need to do the bone marrow biopsy to get the sample, to look down the microscope to see, well, if you've got lymphoma in your bone marrow. And so this is just a diagram showing the movement of the lymphocyte in different parts of the body. Okay? The locations of all the lymph nodes. So we've got some in our neck, armpit, groin, a lot in our tummy, within our chest, around the heart. Okay? The spleen is also part of the immune system, so the spleen can also be involved in the setting of lymphoma. So one thing that I often say to my patients is when you get diagnosed with lymphoma and you go onto the internet and you try to find information about lymphoma, you get all kinds of information. And so it is important to kind of know the keywords that you're looking for. So I often say to my patients, and as some of you would know by now, that lymphomas in essence divide into two terms, okay, two umbrella terms. Hodgkin lymphoma and non-Hodgkin lymphoma. Amongst the non-Hodgkin lymphomas, we've got T cells and B cells. And this is how I divide it. Amongst the B cells, you've got the aggressive lymphomas, and you've got the indolent or low-grade lymphomas. Okay? So today, I'm just going to talk about the low-grade lymphomas. And so that's on the left-hand side. So we're talking about things like follicular lymphoma, marginal zone lymphoma, lymphoplasmacytic lymphoma, mantle cell lymphoma. I put a little star next to it. And that is because although sometimes we do consider mantle cell lymphoma as a low-grade lymphoma, it does sometimes present quite aggressively. And so I often tell my students that I think of mantle cell lymphoma as somewhere in between the low-grade and high-grade. It kind of moves around. And chronic lymphocytic leukemia is also another condition that will fall under the low-grade. Okay? Now, quite often when I get to this point, patients will go, hold on, I thought we were talking about lymphoma. Why are we talking about CLL? Okay? So CLL was chronic lymphocytic leukemia. It is still a low-grade B-cell, what we call lymphoproliferative disorder. It's still abnormal B lymphocyte. But it's just that instead of just sitting in the lymph node, they come out into the bloodstream and they circulate around in your blood. And because we can see them in the blood, we call them leukemia. Okay? If we see them maybe in the lymph node, we call them lymphoma. And so CLL comes under this indolent low-grade lymphoma umbrella. We're not going to talk about the high-grade lymphoma, that's the next book. So when we say low-grade or indolent, what exactly do we mean? So what it means is that in most instances, low-grade lymphoma patients are asymptomatic. They are the things that's been sitting around for probably months, if not years. You've got slightly big lymph nodes. You didn't think too much of it. Went to your GP. The GP got, oh yeah, you've got lymph node. Let's do a biopsy, and then it turns out that it was cancerous. It's a lymphoma. But apart from the fact that you actually went to see your GP to do a biopsy, most patients actually got no symptoms. Okay, they're often very slow growing. Okay, they often patients are asymptomatic, as I said, so they don't feel pain, they're not pressing onto anything. Most of the time it's more of a cosmetic thing because you can see the lump in your neck. But sometimes they do give some very funny manifestations. So your blood count can go low. People can have autoimmune anemia. So the protein produced by the low-grade lymphoma is affecting your immune system and is attacking your blood cell. So you can have these funny symptoms. People can also have something called cryoglobulinemia, which means those funny proteins, they clump together when it is cold. They form a little, not so much like a crystal, but like a clump. And so they deposit around the peripheries that give you nerve problems. Okay? And also it can really lead to something called amyloidosis. Once again, it's all related to the abnormal protein produced by these lymphoma cells. But in essence, most people may have it, they don't know about it, they don't get symptoms, and even when they get diagnosed, a lot of the time, we don't need to do anything. Before we talk about treatment, one other question that people often say to me is, well, okay, I've got cancer, and they want to know what stage they are at. And one thing that I often emphasize is that the staging system in lymphoma is very different to other types of cancer. In other types of cancer, not that I'm an oncologist, so I can't tell you all the details, but quite often you will have stage 1 where it's localized, it's very treatable, very high cure rate. And then stage 4, people have that perception that stage 4 is terminal, it's spread, it's gone beyond control, there's nothing that anyone can do. Whereas in lymphoma, the staging system doesn't really say the same thing. The staging system is more of a geographical description where the lymphoma is. So if you have all the lymph nodes above the diaphragm, then you're either stage 1 or 2. If it's above and below the diaphragm, then it's at least stage 3. So it's just more of a geographical description. And more importantly, the outcome and management doesn't change too much whether you are stage 2, 3, or 4. We'll come to that shortly. And when it comes to CLL, it's even more difficult to describe. The staging system, there are 2 types. One is called Indolent, one is called Ray. And it's not so much about where the lymphoma is, because if you can imagine, the CLL cells are in the blood circulates the whole body, so technically they are everywhere. Okay? But it's more about whether you've got big lymph nodes, big spleen, big liver, and whether your blood count is being affected. The staging system for CLL, from my personal opinion, is more developed so that when people go into clinical study, they can have ways of describing the patient. Okay? And it's a way for the clinical study to decide, okay, what types of patients I want to include in my clinical study. In actual practice, it really doesn't mean too much. Okay? But still, it is important to know that there are different staging systems, and that the concept about staging in blood type cancer is very different to solid organ cancer like prostate or lung cancer. So, a lot of you would have had this talk with your clinicians before, which is the standard treatment for lymphomas or CLL. In essence, if you have localized lymphoma, then the usual practice, if possible, would be to give you radiation treatment. And the idea is that for localized lymphoma, if we give radiation treatment to target that lymph node, potentially we can get rid of it, potentially it is a cure. So that's usually the standard recommendation across the world. It doesn't matter where you go. If you have lymphoma, there's in more than one place, so they can't radiate all the spots. Then the usual practice is you are asymptomatic, which we'll come to shortly as to what is the definition of symptoms. If you're asymptomatic, then we don't do anything. And we just watch and wait. Now, this can be a quite difficult concept because naturally, when you've been diagnosed with something bad, whether it's cancer or infection or high blood pressure, you want to do something about it. It is not easy to say, okay, I've got something going on, but you know what, let's just do nothing. It is hard. It is very hard. But we'll come back to that later as to why we suggest that. And obviously, if you become symptomatic, then we have to do something. And the treatment, as of right now for lymphoma, it is still what we call chemoimmunotherapy. Okay? CLL, similar. Okay? So if you're asymptomatic, we don't do anything. If you're symptomatic, we give treatment. CLL, it is very common. It is the most common type of leukemia in the Western world. And a lot of people have it, nothing happens. And it's a condition that we often say you can die with it, but not die from it. So it doesn't, in some cases, it doesn't shorten your life. You just have it with you. Okay. Now, there's always exceptions when it comes to giving talks like this. Okay. And the exception, there will be alarmists. But just to mention a few things. So, for example, some lymphoma in the gut, I think it's due to or related to a specific bacterial infection, and so antibiotics will work. Sometimes when we give treatment, although we know rituximab is very effective in treating lymphoma, for certain types of lymphoma, we don't use it, or we try not to use it during the first cycle for various reasons, as listed here. And then if your lymphoma becomes aggressive, or if your follicular lymphoma is what we call grade 3B, which is the more aggressive type of the follicular lymphoma, then all that talk about watch and wait and everything, that goes out the window. We treat you like an aggressive lymphoma. Okay. So, moving on. So symptoms. What are the symptoms that we're looking for? Okay. In essence, anything that makes you feel unwell. Okay. So if you have a big lymph node pressing onto something, big lymph node pressing onto your neck, giving you pain, yeah, we'll treat it. Big lymph node pressing onto your kidneys, your gut, your liver, obviously we want to start some treatment. Okay? Sometimes people can be symptomatic because they have what we call constitutional symptoms or B symptoms. They are the things like unexplained fever, weight loss, drenching sweat at night. And so very often when you come to the clinic, these are the questions that people ask you. If you notice any big lymph nodes, if you notice the constitutional symptoms, are you eating and drinking well? Thinking about your bowel, looking at your blood tests, looking at your kidneys, your blood count. Because if the lymphoma is starting to affect any of those things, then we want to start treating the patient. Now, sometimes when the lymph nodes or the tumor mass is really big, so we say more than 7 centimeters, even if the patient doesn't have symptoms, we will still say, yeah, we should start treatment because 7 centimeters is starting to be quite big. Eventually, it will start pressing on to organs, and so you do want to start treatment soon. So this is probably the slide that quite often I spend a lot of time talking about during clinic as to why we watch and wait. Okay? When it comes to medicine, when you ask the doctors, well, why are we doing this? The short answer is always going to be someone somewhere did a study and the results show this. Okay? So this is the answer. The answer is that in the past, people noticed that for the indolent lymphoma, even if you don't do anything, some patients, the lymphoma just disappeared. Not a lot, but they disappear. But quite often they come and go. Okay? And they can go on for years without any problems. And so in the past, people did study comparing watch and wait and giving them some low-dose chemotherapy, something called corendosol. And they looked at the overall survival, it was exactly the same. So giving chemo when someone who's asymptomatic makes no difference. So they thought, well, okay, maybe the chemo wasn't strong enough. Let's do something stronger. And so watch and wait compared to stronger chemo, once again, survival is exactly the same. So that's why currently the guideline is still saying that if you are asymptomatic, we don't need to treat you because in a way what they're saying is because the treatment that we have doesn't really work that well in terms of making you live longer. So why put you through all the potential toxicity? Okay? And the same thing goes with CLL. Once again, they compare it with corendosol, they compare corendosol with chemotherapy, intense chemotherapy. Once again, there is no overall survival advantage. And so for that reason, we say, okay, you're not going to live any longer. There's potential toxicity from the treatment. let's not treat you. Okay? Any questions so far? No? Okay, so when it comes to treatment, one thing that has really changed how we manage patients with lymphoma these days is the medication called rituximab. Rituximab is what we call monoclonal antibodies. So it's antibodies that goes around your system, finds the cells that has the CD20 protein sitting on it. So that is the marker for a lymphocyte. Binds onto it, tag it, kill it off. Okay, so it uses the immune system to help do part of the work. Okay? And so nowadays, whenever you go and you have treatment, rituximab is more or less in every single regimen, as I will show you shortly. Rituximab is an infusion, currently available as an infusion. And most of the time, people can get a bit of a infusion reaction. But that usually happens during the first cycle, and subsequently, people tolerate the treatment very well. And so there are many different types of chemotherapy out there now. And your doctor will explain to you, what they have, the risk and the benefit, and why choose one over the other. And so it is quite impossible for me to go through each one of them and say, well, this is what I think we should use it for, because it all depends on your health, your condition, what treatment that you had before. But one thing that you can see is that the word R, which stands for rituximab, is there in pretty much every single regimen. Okay? The only exception is for CLL, the third one is called obinutuzumab. So obinutuzumab, actually, I think I'm going to teach you guys one more thing. You know how in the word at the end it has AB on it? Yeah. Same for rituximab, it has AB on it. So whenever you see a drug that has the word AB on it, it means that it's a monoclonal antibody. Okay? It's an antibody against something, okay, but it is a monoclonal antibody. So obinutuzumab is another antibody that is against CD20. Okay? You can think of it as a newer version of it, although the drug company thinks that they've done lots of great science behind it. But still, it is an anti-CD20 medication. So you always have chemo, okay, and you always have immunotherapy or these monoclonal antibodies with the treatment. And that's the standard. So I thought I'll just spend a bit more time to talk about rituximab and bendamustine. And the reason for it is because bendamustine, although it has been around for actually many decades now, it was developed in Germany, it's actually only become available in New Zealand. It was only funded last year. Okay, so some of you may not have had this medication before, and you may not have heard too much about it before. But so currently, if you have low-grade lymphoma, usually the first-line treatment is rituximab and bendamustine, and that is based on some of the clinical study showing that using bendamustine instead of, say, CHOP or CDP, patients do better. Okay, so we're going to spend a bit more time just to look at those lines, those curves. So these are called Kaplan-Meier curves. You see that all the time in doctors' talk. We like to show these curves. But basically, if you are on the top line, so if your line is above everyone else, you do the best. Okay, if your line is at the bottom, you do the worst. Okay, so the red line represents patients who receive rituximab and bendamustine. So even without knowing what they mean, you can tell that, well, in most instances, rituximab and bendamustine will do better, will give patients better outcome. And so the top left is actually referring to patients with follicular lymphoma, the most common type of indolent lymphoma. And using bendamustine instead of rituximab, people on average double what we call the progression-free survival. It's in time without the disease coming back or without the patient dying. Okay? So that's a good thing. And in this clinical study, they say that bendamustine is better tolerated. Okay? You don't lose your hair, you can get a rash, the infection risk wasn't that high. And so it becomes the standard of care in many countries, and definitely it is becoming very popular in New Zealand as well. And bendamustine is also being used in CLL as well. So I haven't forgotten about the CLL, because we spent quite a lot of time talking about lymphoma. When it comes to CLL, if you remember the three regimens that I've shown, fludarabine, cyclophosphamide, bendamustine, or obinutuzumab, this is how we often decide on the first line treatment. If you're young and fit, then you get the top line, because it has the most mature data. There is some suggestion that some patients with CLL receiving the top line, rituximab, fludarabine, and cyclophosphamide, potentially they may be cured. Okay? Although we don't know for sure yet, but there's some suggestion. Rituximab and bendamustine is probably not as good as top line, what we call RXC, for all patients, especially for younger patients. But for older patients who are still fit, actually it does just as well as fludarabine and cyclophosphamide. So this is what the curve is showing. So once again, when the two lines overlap, it means that they are pretty much the same. Okay? So the one on the left is for younger patients. Top line is fludarabine, cyclophosphamide. The right one is the curve for patients older than the age of 65. So quite often, if you're slightly older, but you're still fit, then that is what we will use with rituximab and bendamustine. Okay? And then the third one, the obinutuzumab, so it's more for the older patients who have more comorbidities, more health issues. And so it's a more gentle chemo, we think, but it's still very effective in managing CLL. Okay, so let me just check my time. Okay. So that is the basic, that is the standard treatment that you will have had this discussion with all of your clinicians in the past. Okay. Let's talk about something that is not quite standard. Okay. So first thing, we're going to go back to the time when we were saying, for most instances, if you're asymptomatic, we watch and wait. Okay. Now, since the development of rituximab, people go, well, hold on, well, rituximab is quite easy to give, it's quite well tolerated, and it is very effective in lymphoma. So why don't we, instead of watching and waiting, give patients rituximab as a single agent without chemo and see if they do better? It makes sense because remember, part of the reason why we don't give chemo upfront if you're asymptomatic is because of the fear or concern about toxicity. So they've done the study. So on the left two curve looks at giving rituximab single agent, just 4 doses, or 4 doses with what we call maintenance, so you keep going, compared to patients who watch and wait and did nothing. And what it has shown is that if you give rituximab as a single agent, whether followed by maintenance or not, you keep the disease away for longer. Okay, so what we call the progression-free survival, the time to its treatment, is longer. So you don't need chemo until later. Now, obviously, you can say, well, but I am getting treatment. It's not like I just get treatment and I do nothing. You are getting treatment. So there's some, it is still very debatable. Okay? And more importantly, even if we give rituximab a very good treatment for lymphoma, unfortunately, as shown in the middle curve, your overall survival is still the same. Okay, so spend the money, get the medication, is potentially can keep the disease away for longer, but you don't live any longer. Okay, so that's why we don't typically do it. Okay, and it remains a very debatable issue. And then the third graph just basically illustrates the same point, that if you are going to do it, if you just have 4 doses, it's probably easier, cheaper, and better just to do 4 doses and then do nothing. And then if it comes back, give another 4 doses, rather than having 4 doses and then going on to a maintenance. Okay. The concern of maintenance is that it is costly. It does have some potential long-term toxicity, including infections. Patients do feel better. Their quality of life, their anxiety is slightly better when they know that they're getting treatment. So that's rituximab. Another controversial thing about rituximab is using rituximab after you have finished your chemotherapy. Okay. So currently, as you may know, say for example, follicular lymphoma. Okay, we will give you chemotherapy, 6 cycles of rituximab-based chemotherapy, and then we stop. And people have done study go, okay, what if we don't stop? We finish the chemo, and we give you more rituximab, 1 dose every 2 to 3 months, and we do it for 2 years and see what happens. So,
do you give it as a pill, or how do you give it?
it's an infusion. So
Yeah.
rituximab is the infusion that takes about 4 to 6 hours,
Yeah.
the first infusion. So you basically come back to the day stay or the treatment center every 2 months to have the infusion. Okay? And so what they have shown is that once again, just like anything with single agent rituximab, if you take it, it keeps the disease away for longer. Right. But unfortunately, just like my previous life, you don't live any longer. So then all the clinicians are thinking, well, okay, if you don't live longer, what's the point of doing it? So quite often, obviously, currently rituximab is not funded as maintenance in New Zealand, but some country will do it. So when I was in Toronto, they would do it. Some countries won't because there's no survival benefit. You don't live long. But potentially it is, it is something that can be considered if, let's just say, money is not an issue. But of course, you need to weigh out about the inconvenience of having treatment once every 2 to 3 months and do that for 2 years. But there's certainly something worth keeping an eye on. Sorry? Let me just think about the study. Initially, people feel better, but then in the long run, the quality of life seemed to be quite similar. So they asked surveys, say, do you feel better? People at the end say, no, they feel more or less the same. Some people feel, I believe that people feel less anxious when they're getting the treatment. But after 2 years, it's more or less the same. But what is interesting, though, is that although rituximab maintenance hasn't been shown to improve your overall survival in first-line setting, there is data that if you use it when you have relapse, so you have 1 line of chemo, the cancer has come back, you give the chemo again, and then this time you give rituximab maintenance, there is some evidence that people live longer. And this has been published about 4 years ago. And the treatment is given every 3 months, once again over 2 years. Now, as of right now, it is not funded for this purpose, and anything to do with long-term maintenance treatment is always very debatable because we are asking the patient to come back every 3 months to have an infusion, so the inconvenience and also the risk of infection or long-term toxicity associated with rituximab, it is still there. So, but you never know, it may become available in the future. People never like chemotherapy. People never like, cyclophosphamide, doxorubicin, vincristine. They give you side effects like, you lose your hair, pins and needles, and affect your heart. And so the field is trying to go, okay, if we don't use chemo, if we just use rituximab with a long chemo medication, can we do that? And this is one of the latest studies that was presented a few months ago, looking at rituximab and a medication called lenalidomide. Now, for those who have myeloma, they are quite familiar with the medication lenalidomide. Not so much for patients with lymphoma. Lenalidomide is what we call an immunomodulatory medication. And what this study is showing is that potentially, if you use rituximab and lenalidomide together, it will work just as well if you use rituximab and CHOP chemo together for patients with follicular lymphoma. Now, I'm not saying that lenalidomide is the best. Okay? It does have other funny side effects. For example, it can give you quite bad diarrhea. Manageable, we can give you medication to sort that out, but it can give you diarrhea. There is some data to show that lenalidomide increases your risk of secondary cancer. I'm not saying that the chemotherapy doesn't, but so unfortunately there's no perfect solution, but the good thing about lenalidomide is that it's just a tablet, whereas the CHOP chemo is an infusion. So it's all about convenience. So what else is in the horizon? Currently, when you come and you have lymphoma, we do a biopsy, we look down the microscope, and we say, okay, it looks like follicular lymphoma or whatever lymphoma, and we say, okay, this is the treatment. And we pretty much have some risk stratification tools and say whether you're high risk or intermediate or low risk. Okay? But currently, what the field is trying to do is to have more to move into what we call precision medicine or molecular profiling, and actually look at the genes in the lymphoma and go, well, okay, have you got any of those high-risk genes or low-risk genes? And so this is just some studies showing that if you have high-risk genes, you do worse. If you have low-risk genes, you do better. Now, it's great from our point of view because we can say, well, whether you've got high-risk or low-risk. But until the day that we've got very effective treatment that we can say, okay, if you're high-risk, you get A, and if it's low-risk, you get B. A lot of the time for the patients, it's like, well, okay, you're not going to do anything differently. Why are you telling me this? You're just increasing my anxiety, you know what? Okay. But still, that is unfortunately how the wheel of the of science moves. You know? It moves slowly, and you get information. So that's why I always promote clinical trials because we need that data, not just in New Zealand but across the world, so that we know how best to manage patients. So often what we now also see is that if you, after treatment, especially for follicular lymphoma, if you don't progress within the first 24 months, you do very well. Okay? Unfortunately, if you progress within the first 24 months, you don't do so well. Is it helpful for patients? Well, if you're in those who haven't progressed, then good on you. Obviously, for those who progress within 24 months, you know, it's the same thing as the molecular profiling. It's good to know. At the same time, it's really that good to know.
What do you mean by progress?
So progress is in the disease coming back within 24 months after chemo.
Is that when you are diagnosed or when they?
So after treatment. So the other thing that you guys would have heard about is PET scan. PET scan is pretty much just like a CT scan, but on top of that, it looks at the activity of the tissue. So quite often after we give chemo, there's some residual lymph nodes, and if the lymph node, just on a CT scan, it may look a little bit big, and we don't know whether it's just scar tissue or residual cancer. And PET scan will have the ability to look at it. If the lymph node is still very active, it will show up on the scan, just like on the picture on the right. And so we know, you know, whatever there's left there is not just scar tissue, there is cancer. And there is now data showing that, you know, what we should try to aim for is instead of just doing a CT scan at the end of treatment, doing a PET scan will give us more information about your prognosis. Okay. Now, please don't go back to your haematologist and say, I want a PET scan. I heard Henry say PET scan is the best thing. Yeah, because of, you know, obviously limited resources. Yeah. Okay, so that's all the lymphoma what is out in the horizon. When it comes to CLL, just going to give you, some, just draw you what the picture will look like in the near future. So nowadays, we quite often talk about something called minimal residual disease. Okay? In the past, when we assess treatment response, either we say it's a partial response, so your lymph node has half in size, or complete response, as if we can't see the lymph node. But then your hematologist will say to you, well, even though we can't see it, we can't say that it's all gone. Okay? And minimal residual disease basically look at to see if you've got a very small amount of residual cancer cells in your body using the latest technology, something called flow cytometry or molecular study or next generation sequencing. Now, the picture on the left is more about myeloma, but CLL basically talks about the same thing. So you can see that the CLL is only about halfway down there. And so just because you have achieved a complete response and I can't see it down the microscope, it doesn't mean that you don't have it. And MRD is basically looking at further down here. So we're talking about a very deep response. So if you're MRD negative after treatment, you do very well. And currently we are using that quite a lot because, say for example, at North Shore, if I have a patient, I give them chemotherapy and they're struggling through, after 4 cycles, they're really tired, they can't go on anymore, I would sometimes use MRD test. And if they're MRD negative, then I go, well, we don't have the data on it, but you have achieved a very deep response. So maybe it's okay for us to stop now instead of pushing for those 2 more cycles. Okay? So that's what we call response adaptive therapy. Now, the data on this is still very immature, but still you can see how instead of just blindly going in and say 6 cycles of whatever, we see how deep you respond and then we change the treatment based on how well or how not well you have done. And some of the newer medications coming down the pipelines include something called Bruton tyrosine kinase inhibitors, and one of the medications is called ibrutinib. This is an oral tablet, very effective in CLL, and many studies have shown that it is very effective, if not better, than the standard treatment. And one thing that I want to highlight, because I know that time is running out, is another medication that IB is a protein inhibitor. So, for example, in CML, you have imatinib, so it's IB, so it inhibits a kinase. Sorry, just going to go to this slide. So there are many of these new drugs coming through. Obviously, they are not funded, but there are quite a lot of clinical studies going on. So, for example, at North Shore, we have got a lot of experience in using this medication called ibrutinib. It's a newer version. You can think of it as the newer version of ibrutinib, and it is very effective in treating CLL. We've got studies going on for CLL. I think we've got one starting for marginal zone lymphoma. And it's just a tablet that you take, and it's very well tolerated. Same as I covered ibrutinib. There have been quite a lot of clinical studies looking at it in other types of lymphoma as well. And just to draw your attention to some of the latest stuff, so we've got this study called Captivate in North Shore. Basically, you combine the ibrutinib with this new class of medication called venetoclax. Once again, affects different pathway of the CLL. And as you can, and what is shown is that just having oral tablets, after 9 cycles of treatment, 86% of them were more or less MRD negative. So remember what I said about MRD negative a few slides ago. If you're MRD negative, you do really well. So we think that these novel new drugs in the future is going to change how we manage CLL. Maybe one day we no longer need to use chemotherapy. It's just going to be a tablet, just like taking tablets for your blood pressure. That would be good. So one last thing, people often ask me, what can I do to improve my chances? And I always say to them, stay active. Okay? It doesn't matter what you're going to get. It doesn't matter what study you look at. The better your physical function is, the better the outcome. It's always the case. There's studies showing that if you stay active, you feel better yourself. There's some studies showing that people who stay active, they survive longer. Now, obviously, there's some confounding issues here. People who are active are usually young and therefore most likely to do better. But still, staying active will definitely help. So there are lots of things in the future coming down the pipeline. So I think for indolent lymphoma in the next 5 to 10 years, the management will be very different. And so, we are hopeful that hopefully one day we can manage these diseases just like any chronic disease. That we don't need to worry too much about survival, and potentially we can one day use the word cure. Although we're not quite there yet, I'm sure we are getting there. So I'm sorry that I actually took longer than I thought, but we've got time for questions.
Yes, thank you.
Yeah.
Normal, have you seen it that a patient has got polycythemia vera as well as non-Hodgkin